It's an honor for me to be with you today and to be able to share some of my thoughts on healthcare, the transformation of healthcare that is needed, what's gone on recently, introduce some of the concepts that you'll be talking about over the next couple of days, concepts that involve cost and involve access, involve issues surrounding quality. What I'm going to run through, and we don't have turn my clock on here. We don't have a lot of time, so I'm not going to go through all of these, but I sort of lined up some things that might be interesting for you to set the big stage. Then you can fill in a lot of the gaps over the next 2 days. I won't get through this whole list. I want to save some time for questions and answers, or questions and discussion as we go through, but would like to talk a little bit about politics just because of the season right now, some implications for healthcare, global comparisons to ask that basic question of why in the world do we spend twice as much as every other country in the world? We don't have universal access, but our outcomes are miserable compared to other countries in the world. Ethics of reform, which is where I think every conversation with healthcare should begin, or healthcare reform or transformation. What are your ethics? What are the ethics of a population? Clearly, as a political figure, I start with that, and when I'm teaching in a class, I start with that, or start that class as well. If you tell me what your ethics are, I can design a health care plan for you. Behavior, and I should put behavior/wellness, and I'll come back to why I'm spending or want to spend time on that. Increasingly understood, it doesn't come across in the campaigns that cost drives the whole issue of the uninsured. A comment on pay for performance and evidence-based medicine, and also a vision for the future, because I'm very, very optimistic. I've spent about 20 years in medicine in a very exciting time, and basically what I did every week was transplant hearts and transplant lungs, and transplant heart and lungs, taking them out of one person, putting them in another. I began it at a time where it was not done routinely. In fact, it was not done but except at one center in the world, and that was at Stanford University Medical Center. And the interesting story about that is that when I was at Boston, I'd done all my training at Harvard Medical School, Mass General, and considered at the time sort of the best of the best. Yet in about 1981, they said collectively, Mass General, where I trained, Peterbilt, Brigham, and Beth Israel, that based on all the knowledge that we have, heart transplants really can't be a reality, and therefore we're not going to do them in Boston, Massachusetts. And that's pretty interesting for me because I, at the time, fairly young, but had done my internship and residency in cardiac surgery and trained to be thinking creatively and dynamically and innovatively, and then all of a sudden have the best of the best say, no, we're not going to do it. So I left, and at the time I was slated to stay there, and in fact I'd probably still be there today if they hadn't said no, not just to me, but to the entire community. No hospital could do it, and left and went to Stanford. And there's one fellow, Norman Shumway, whose mantra was sort of conceive something and then believe it and then just do it. And nobody else in the world was doing it. They said it really couldn't be done, and he did it. And then a few years later came back to Vanderbilt, and with the support of the university started doing heart transplants. Lung transplants had never been done anywhere successfully. We started doing lung transplants and then neonatal heart transplants, little babies, and heart lung transplants, set up a large transplant center here. Did that for 20 years and then moved over to politics, basically to extend that healing one-on-one to healing on many. And if you look at some of the things we won't talk about today, but PEPFAR, HIV/AIDS legislation, some of the most important legislation in influencing millions of people now and tens of millions of people in the future, we were able to do in Washington, D.C. The Medicare Modernization Act, the single largest piece of health legislation in recent history, was written, basically giving affordable access to 40 million people to prescription drugs for the first time through Medicare. Some people say it costs too much, it's a bad program, but I can tell you as a physician, to deny seniors affordable access to prescription drugs and at the same time through Medicare promising them health care security is wrong. And we fixed that, and that particular program has come in actually pretty good, about 30%, costing 30% less than we thought, benefits about 20% more than we anticipated, and today it's one of the, if not the most popular federal program in existence. Now, here I am. Who do Americans trust to tell the truth? You can see teachers up there pretty high, clergy I have in yellow there, judges I have there, but look where members of Congress are. So here I am. I got Nancy Pelosi there, but unfortunately, that's where luckily I can say was. So, should you believe anything that I say? And in an audience like this, a lot of you, hopefully, are going to go into figuring this stuff out in the private sector. And unfortunately, you can't laugh too quick because look who's down there, health insurance. They can't trust them either. They're down around 28%. But the hat I wear today is up at the top. Doctors. 85% of the time you can trust them. So when you look at me, forget the majority leader, forget being in the United States Senate, and he's a doctor and I can trust what he says. I have to also open with this slide really provided by the National Healthcare Council because it really does tell the story of Nashville, Tennessee and what's so unique about this community. And one thing I learned in sitting with about this many people, all senators, is every day is the appreciation they have of the expertise and the generations of management and administration that have come out of Nashville, Tennessee. 300 public health companies, 15 of those public, 310,000 employees, $45 billion of revenue passing through this city. Again, the public companies, just to sort of graphically capture, there is no other city in the United States of America that can make this claim. And so as you go through the next 2 days, you listen to the speakers, the expertise, you're really getting, except for me, the best of the best. The family tree, I have to show this because as some of you know, I've just redone my house that I grew up in, was born in over on Bowling Avenue, not too far from here. And Dad's office was right across the street where Vanderbilt Plaza is for 45 years. And it was around the kitchen table that I still have in my house when you go by Bowling Avenue, the same kitchen table there that my brother came and talked to Mother and Dad when he was about 29 years old, said, I've got a vision. And Dad said, forget the vision stuff, you're a doctor, take care of patients, because he was a doctor at the time. And he said, no, there's something out there, that there's this chaos in healthcare out there that nobody's giving focus, nobody's applying business principles to this huge sector of our economy, that's the hospitals out there, and it's a cottage industry. Nobody's talking. The boards themselves are sort of the local barber, and they have no business experience. Why don't we just inject a little bit of that discipline? And indeed, Hospital Corporation of America was founded really around that table. Dad said no, Mother said yes, follow your son, even though it's a crazy idea. And since then, and with hospital affiliates, there have been 300 companies that have been formed here in Nashville, Tennessee. Again, no other place in the world can claim this heritage and this legacy. Again, a real blessing for all of us. Politics, okay, I have to be real careful with this because I get quoted a lot. So I say if the election were today, so before coming over here this morning, I go on realclearpolitics.com, a great website for you to see, and it leads me to the conclusion that the Democrats will dramatically increase their control of both houses. If the election were today, Democrats will pick up 28 seats, net 28 seats. That doesn't matter, that matters, but it doesn't really affect policy. That's not going to affect your lives very much because Democrat control of the House is what's important. And that means Nancy Pelosi will be setting the policy for the United States of America. It doesn't matter who the minority is there. The Senate is very different. The Senate is a minority-driven body. That's the way our founding fathers set it up. It is to counterbalance the passions of the House. There, the elections are critical because how close you are to the minority determines whether or not the politics of Nancy Pelosi will become the politics of America, of Nashville. Well, I'm not saying that's good or bad, but Nancy Pelosi, if you take all of the people in here, would be the most liberal person in that body, in the Congress, or within the 10 of the 435 people, she'd be in the most liberal, where America is center or right center, and she is way to the left. So how do you balance that overall? Again, I'm not, whether it's good or bad, doesn't matter to me, but how do you counterbalance that where America is in a different place? The overwhelming majority of America is in a different place. And then it comes to the Senate. There, as you know, the majority threshold is right at 40 votes, and it's going to get right down to about 41. I say pick up net 8 seats. Right now it's 49, 1. Lieberman, who is basically a Democrat, sits with the Democrats, but I don't know what he's going to do after the election, and then one socialist who is, in the socialist category officially. And so it's really 49, so it'll take us right down to 41 or 40 seats. So it'll be an interesting time. In the presidential election, at the election day, Senator Obama would be president of the United States. In all likelihood, you can't really bet, but probably 95% chance. I put on here the market odds, in-trade market odds in the black there, the second down from this morning is about, if you're betting, all the bettors out there are putting about 83% on Obama today. The polling data, if you take 200 polls and you average them over the last week, Obama 49, almost 50%, McCain 43.8. And you'll hear a lot this morning about a couple of polls yesterday swinging towards McCain, so it will be close. He has to pick up all 5 sort of questionable states that are out there that nobody's really willing to go. He has to pick up all 5 of those and Pennsylvania to get these electoral votes, which are now 311, 142, to get it down. You have to have 270 electoral votes. So you'd have to get all 5 of the questionable states now, plus Pennsylvania has 21 electoral votes, and then you get to 270. Then one other state has to break. So I don't see how it can be done, but it could be done. And it'll tighten, and what's the Bradley effect in terms of race? I don't think it's as big as people say. Graphically, this is what it is. Just again, so you'll get it. We'll go through this fairly quickly. Right here, this was the convention. This is, over here is September 2007. This is as of this morning today. So you can see what the trends have been really over a period of time, except for this little blip of the convention. So Obama, McCain. Now this is the popular vote, so the electoral vote is really what you want to follow. So in all likelihood, the next president will be President Obama. Health care for both of these guys. Don't spend too much time on over the next couple of days as you're talking, because it really doesn't matter. It's not what's going to happen, but it is important to know the basics. McCain has really no mandates. He basically has the more radical plan. He has the plan that says we have 60 million people in employer-sponsored plans. Let's blow that system up structurally. You want people to keep doing it, but you take away the huge tax advantage, about $300 billion, and you take that and lift it, and then you distribute it to everybody. And so everybody will be treated equally. That's a big change. That's a radical change. Obama is really shifting things around, more government, new government plan. The radical plan is McCain's plan. Then he gives a $2,500 tax credit for each individual, or $5,000 for a family, and then some state grants, real nebulous in terms of how you take care of the uninsured. The Obama has the children mandate, all children. He didn't go as far as Hillary Clinton. Hillary Clinton said universal health care. He never did that, and I think it was wise. And basically he said, let's get universal care for children and go as far as you can for others. The big one that I worry about with him is creating the new public plan. The government is going to come in. Sounds good because you have the uninsured that are out there, but the government plan, having been in government, having been at the top of the government, as majority leader, bothers me. Because that new public plan, especially when you say and use the words repeatedly, I'm going to give you the exact same policy that Bill Frist had in the United States Senate, when you say that to 45 million people. How do you do that? Because I know how much my plan costs. Your plan, an average for a family right now, is up to almost $13,000. Average right now in the private employer-sponsored market. So it is very, very expensive to do. If the government offers the plan, you can drive the private sector out. Because when they come to the bargaining table, if you lowball everything there and you do it on purpose, you say, well, that's good for competition. At some point, the private sector jumps out of the system and you have just a pure government plan. That's what bothers me the most. Let's listen just a little bit to what that is in their particular words.
Universal coverage with all the tax increases, new mandates and government regulation that come along with that idea. But in the end, this will accomplish one thing only. We will replace the inefficiency, irrationality, and uncontrolled costs of the current system with the inefficiency, irrationality, and uncontrolled costs of a government monopoly.
So government versus markets is sort of the basic thematic.
You already have health insurance. The only thing that will change for you under this plan is the amount of money you will spend on premiums. That will be less than what you're spending now. But if you're you're one of the 45 million Americans who don't have health insurance, you will have a new plan after this plan becomes law. You will have health insurance available. Now, to help pay for all this, we will ask all but the smallest businesses who don't make a meaningful contribution today to the health care coverage of their employees to do so by supporting this new plan.
Americans need new choices beyond those offered in employment-based coverage. Americans want a system built so that wherever you go and wherever you work, your health plan goes with you. And there's a very straightforward way to achieve this. Every year, they would receive a tax credit directly with the same cash value of the credits for employees in big companies and a small business or self-employed. You simply choose the insurance provider that suits you best.
Well, I'll stop with that, but you get a feeling the first words out of a Republican's mouth is basically let's lower costs, let's use markets as sort of the rationing device. The first words out of the Democrats' mouth is always access, universal care, promising everybody coverage. Don't pay too much attention to that because basically they're both playing to their bases. And when it comes down to it, you're going to have to bring that together. And we'll come back and talk a little bit about the relationship between cost and spending and access itself. But I think the approach is important that from the Democrat side, and Democrats are going to run the Senate, the House, and the presidency, government will be the answer. From the Republican approach, it'll come back and say that the individuals, you need to empower them. You have to have massive change to be able to empower them. Are we ready for that? Is there enough transparency? Do we have enough information out there to have what one of your last panels is on consumer-driven medicine today and consumer-driven healthcare today? Again, I just remember that the McCain approach is to blow up the employer-sponsored system, take that bundle of money and then distribute it equally where everybody, if you're in the individual market or you're playing the guitar here on Music Row over here, when your employer's not going to buy your insurance, that you are empowered with $2,500, $5,000 to go out and buy a policy. Do you need insurance reform to lower the price of those policies? Because I just told you on average it's up to $12,777 for a family of four today, and the answer is yes. And how do you deregulate the insurance market, or do you regulate it to force that sort of transparency and lower prices? Those are the sort of issues that we'll be dealing with. Global comparisons. Think right now, and I introduced the question: why, if somebody were to ask you tonight at the Halloween gathering, not somebody in this room, why is it that we do so poorly in health care, in infant mortality, or how long we live? What would you say? Just let me ask people out there, why? We spend so much money and in appropriately adjusted dollars. Why is it? Anybody have any thoughts? Inefficiencies in the system, clearly. What else? Anybody, just throw it out, decide something to.
High cost of paperwork.
Paperwork, red tape, poor physicians in hospitals over there who just walk in and they see a bunch of papers with 1,000 different health plans out there. Why is it that we die sooner, and why is it that our infant mortality is higher than any nation in the world in spite of spending twice as much? Lifestyle habits, behavior.
A lot of those dollars go towards very small marginal improvements.
That's right. Incremental improvement on the margin and technology is a good example. Latest technology may not improve outcomes at all.
Hasn't been a focus on evidence-based medicine.
Evidence-based medicine, pay for performance. Does that improve evidence-based medicine? How good is the evidence out there? As a doctor, we don't like cookbook medicine. Is that what evidence-based medicine is today? Well, let's look real quick. Basically, the data, just graphically, that's the U.S. total healthcare spending per capita. That's adjusted for cost of living, and I dropped off all the footnotes, but fully adjusted. The point is we spend per capita twice as much adjusted for cost of living than any other country in the world. Big picture, allocation of resources. What I deal with in the budget itself is a percent of GDP. It is also about twice as much, 16% on average, about 8% around the world. So how much we tend to invest there is twice as much, and that means less probably on education and other things. The results, infant mortality rate, if you have 1,000 live births, and people say, I don't believe these numbers. The numbers are real, unfortunately. We have 7 deaths in this country. So if you really want, if you're pregnant or you can have a family, it's almost better to move to another country, and that's pretty amazing in terms of how much we spend today. And the real question is why? And I think the range of answers we got, about 5 answers, are pretty good, but I'd probably answer it a little bit differently. Life expectancy at age 60. So not only is the infant mortality, which kind of represents the systems and the socioeconomic conditions, but also how long you're going to live. Look at all these other countries to the left. This is after you reach age 60. I could have taken it from age birth, but after age 60, you can live 18 years, 20 years, 24 years, and you can see that we're out here at 15 and 18 years, and over here at France and Spain and Sweden, it's up at 20 and 22 years. Pretty interesting, I think, and the most powerful, richest, most technologically advanced in the world today. So this is a little baby starting on the left, old, death in the right. What determines? I just take this one, how long we live. You can do the same thing with infant mortality. You give me the index, and I can design the same sort of chart. The chart is based on 200 studies that were put together, and the studies through a meta-analysis come up with the following. And ask yourself right now, as I'm talking to you, how long are you going to live? What determines that? Number one, or what you can start with, is genetics, who your parents are. Pretty interesting, and even more interesting when you think that now we're entering this era of personalized health medicine where we can start manipulating those genetics. It's fun to think about that, and it's fun to, from a scientific standpoint, to talk a lot about that. Social circumstances, how rich you are, where you live, your education, 15% in terms of how long you're going to live. That's not as high as what most people, when you actually have to guess. Most people would say, well, if you're wealthy, you should live a lot longer. Or if you live in a suburban Nashville versus downtown New York, you should live longer. But really, it's not as big as you'd think. Environmental exposure is 5%. It varies a little bit where you live, but if you put all the studies together, it's only about 5%. And the big one that you did come to was behavior. It's about 40% of the kick. And what is interesting to me is that everything I've talked about to date in terms of universal health care, or you heard Obama talk about, or you heard McCain talk about, really is on this last one, 10%. How long you're going to live is only 10% dependent on Vanderbilt Hospital, Bill Frist doing heart transplants, your physician, how it's organized, access to health care, and all those things. So everything else we're going to talk about today, in truth, is important and ultimately sort of why we're here. But if we want to answer that question of why spending twice as much as any nation in the world, you got to come back to this. And indeed, just real quickly, I think as we look, especially in an entrepreneurial place like Nashville, I think you do have to start linking behavior to health services. And Healthways is obviously in that business, but whatever business you're in, I think you need to be thinking of these sustainable business models to link those two together. Let me just take social circumstances real quick just to give you an example. I do the same thing. Sometimes I take genetics, which is actually a fascinating one. Let me take social circumstances because most of you live here in Middle Tennessee and in Nashville. Right now, a snapshot of Tennessee in terms of I'm going to go to health potential, but very quickly I'm going to go to education. The Robert Wood Johnson Foundation just did a study, and although nobody reads newspapers anymore, thank goodness, because they're not very good. They're terrible. The quality of reporting is just, I think, miserable from an ethical and a professional standpoint. But in the Tennessean, I published an op-ed piece about, it was also on .com, their .com, but on linking healthcare to education. And the reason I did this, just focus on the left side of this chart, forget the right side of the chart. It links infant mortality here in Tennessee to education. It's a correlation, but we're running the sort of causality behind it. But let me just show you the correlation real quick. This right now is, well, first you focus on the right here, 6.5 deaths. This is infant mortality per 1,000 is the U.S. average. We're about 30% worse than that. We're 8.6 in Tennessee. So the question is why? Do we need to build more neonatal intensive care units? What do we need to do? One thing that I wanted to look at was education. So if you come over to the left on this side, you see this bar has 11.7 or almost 12 deaths per 1,000 births. And who is that? It is the woman who has less than a high school education. If you look at the 4.9 that people are doing very well, it is the people who have graduated from college itself, and you can see that there's a gradation there. And the findings of this particular study, and looking at that gap, put you, Tennessee, the worst in America. And indeed, the findings are this. Tennessee ranks 50th among states based on the size of the gap in infant mortality by mothers' education. And the point of me showing you this is that if we really want to improve health and the health of a community and infant mortality and how long you live, forget health services, forget the hospital, but come back and look at these other issues like education and obviously behavior, which we'll come to shortly. So if Tennessee fails in education, it's going to fail in health care. So pay attention to what happens to K through 12, education reform, but also the United States of America, going back to the original question. If we're failing in education, we're going to fail in health care as well. So where are we right now? America's 15-year-olds ranked 21st in science and 25th in mathematics. On the left here, you see science. Here you have Canada, Japan, New Zealand, Australia, Netherlands, Korea, Germany, United Kingdom, United States, 21st. In math, same thing coming down, 25th. Pretty unbelievable given how rich this nation is. And I show that, and then I got this thing blinking up here, an economic necessity, because if you right now have, let's say, 20 people, the first two rows here are coming in to see me, and I'm an employer hiring, and I'm looking at the greatest, really global challenge out there, energy today, and I need people who understand science, and I need people who understand math. Am I going to pick anybody, because we only got one person from the United States? I'm going to pick 19 other people before I pick that person from the United States. So if you look at our world and the global connections that we're talking about, and all of us are struggling with the economy here in the United States, it's happening around the world. And who's going to help lift us up? It can't be the United States of America, because right now our capital, our human capital, is the worst in the developing world. So a lot to do. I throw all that in really just to introduce you. And one final thing on education. The dropouts are huge. 1.2 million students drop out. American students of high school every year. Over in Memphis, where I was the other day, 48% of the kids drop out before they graduate from high school. A lot to be done. Focus on K through 12 education reform, and that's just an example of why we don't do as well as we should in healthcare. Ethics, let me just turn to the ethics end of things. Basically, as a politician, as a public policy person, it falls just kind of like this room, evenly divided. And as I said, you need to determine which camp you are in. Do you think of healthcare as a consumer good whose financing should be the responsibility of those people who receive it, and that ultimately rationing is done by some level of socioeconomic status, or do you look at it more of a social good that should be equal to everybody in here? You should have an equal shot at it, and the only thing you need to pay is based on your ability to pay. It does require a rationing that is generally done by central government. And do you trust government or do you trust individuals? As I said in the opening, I would pick which of those two schools you are more likely to be in. And if you do that, you come to the policymaker, we can design a plan for you. Wellness and behavior, 40% kick that I showed you in terms of outcome is something that, again, I bring and concentrate on in part because I don't have the answer to, but you need to figure out the answer to that if we want to improve health of the American people. Right now, all of you know the whole obesity epidemic. It's interesting. It's really been only the last 30 to 40 years, 1991, 1996, 2001, 2007. As you get to the green and the yellow, increasing obesity, it is there. What is interesting is that all of the CBO projections, all of the government projections that you hear and that you read about, that are in the articles, that are in handouts, that you hear about at conferences, all of those are based on the previous 50 years where health was improving over time, where people were living longer and longer, where there was less morbidity. We didn't have obesity. We had smoking. That's gotten a little bit better. But overall, the health of the American people from 1910 to about 1960 was getting better and better and better. Those are the assumptions that are in those demographic projections going forward. So everything that you see, don't take into account this epidemic, which is occurring in the young as much, in adolescents as much as in the elderly as well. So most of those statistics are even worse than what you actually see. Total health care cost, because we've got to get back to cost. Republicans will say cost, Democrats will say access. In truth, it is both. What is driving cost in health care today? We know the end-of-life issues, but the things that we should be able to manipulate and can manipulate, you can see about 70% are modifiable risk. And again, if you were to break those out, you see that it is blood pressure, cholesterol, poor diet, obesity, lack of exercise, smoking. So if we really want to hit this cost some way or another, we have to develop business models that will address this wellness, this prevention, this lifestyle that we have today. This is what we usually measure And this is where economists try to help out, but I don't really think economists are very useful for most policy. But the economists are good at least in trying to quantify and putting together in equations what drives in terms of inputs and outputs. And we look, and insurance companies tend to look at the direct medical cost, but it's only about 24% of the total. Insurance companies have a huge disadvantage in our country because the average person stays with that company for 2.3 years. And therefore, when you talk about prevention, why would they invest heavily in prevention up front when that individual with certainty is not going to be around in 6 years? I worked for a year in England for the socialist system there. It's increasingly not socialist, but it was when I was there in 1984 or 83, and spent a year working for England, the National Health Service, doing heart surgery there. Full-time, they were my job. That was what I got paid doing. And it was interesting, and they have a huge advantage in that that patient who is in that system is there for 5 or 10 years or 15 or 20 years or 30 years. And therefore, the government does have more of an advantage of investing in prevention if it's evidence-proved type of prevention. All prevention is not cheap, but they have more of an incentive that our insurance markets do today. The indirect medical cost is where we've got to continue to define and refine and give discipline to as we are both policymakers and students. And again, this article is out of the Harvard Business Review of several years ago, and the numbers don't matter, but the indirect medical costs, when we're looking at things like wellness and prevention, are huge and about 3/4 of the overall cost. And that's defined in long-term disability, in absenteeism, that is the days that are missed, and also presenteeism, the sort of aspect of people being there. Are they productive while they're at work? We all need to continue to take this big picture and then figure out how we build insurance models around that. My challenge really to you is to develop a sustainable business model for this. I went on a search to look for a wellness program that you could truly make a long-term business model on in terms of lowering cost over time. In the United States, you can't find it. We did a large demonstration project under the Medicare Modernization Act of 2003 when I was a majority leader on chronic disease management, taking these sick people and trying to manage them. We terminated that because nobody can show that chronic disease management using today's technology really saves money. Now we know that it does, and that's why we set up that project initially, but of the 6 companies out there, nobody came to the table and conclusively proved you save money by managing these patients. But we know that it happens, and I believe that it does happen, and those tools are being refined. So it's hard to develop this business model. I did find one company in South Africa, a company called Vitality. The reason I had to go to South Africa is because even their private insurance model, because they're so dominant, keeps that patient for up to about 8 years on average instead of 2.3. And therefore, they are willing to invest up front because they know they'll realize that payout over the next 8, 10, or 15 years. And indeed, this company is called Vitality. It's not yet here in the United States of America, but I couldn't find anything in Germany, I couldn't find anything in England really, and I couldn't find anything in the United States that with good data over a long period of time demonstrated this. And again, the numbers don't matter, but these arrows show improvement with a highly engaged population in admission rates for cancer, for cardiovascular disease, for endocrine and metabolic disorders, and for bone or musculoskeletal disorders. And then if you look at cost per patient, per inpatient event, cost also fell by this much. And then their conclusion was that if you get these highly engaged members, you will have lower cost per patient, you'll have shorter stays in the hospital, and fewer admissions compared to all of the other groups. The data, don't even pay too much attention to this data, but this is what we've got to work towards. If you really have good prevention, good chronic disease management for heart failure, for diabetes, for depression, do you actually save money over time? And if you get that sustainable business model, we can hit that 40% of the equation coming in terms of the impact on how long you live or other outcomes of measurement. We have to think outside of the box. And both in my medical school training, last year I spent a year at Princeton looking at healthcare policy and did my best to start getting into it. And we'll talk a lot about it in the course that I'll be teaching at Owen this January. We have to think outside the box. So how do you actually change behavior? And Subway basically said about 2 years ago, we want to change behavior. We want to be a part of this wellness movement that we know will ultimately influence productivity in this country and how long people live and economic well-being and fulfillment in life. So they basically started with the following. Description of the situation. Subway sandwich shop menu includes 10 sandwiches ranging from 280 to 580 calories each. They basically said, well, let's take 3 different approaches and compare them to see at the end of a year, if you aggregate all those sandwiches, if people are eating healthier than they would otherwise. And so the first thing they started with, that's just, for those, it's hard to see, but this is a picture of their sandwiches, like on their sandwich board. And then the first thing that they did is basically list the calories, just like here, underneath calories, 280 calories, 290 calories. As all of you know, New York has, through Bloomberg, who's a great leader in public health, both in smoking and now in obesity, you can't go to a restaurant now in New York City, as of this past month, that doesn't have the calories listed there. And people are learning that those salads have 3,000 calories in them, which is pretty interesting as you go through. That healthy salad that you've been getting, that steak, all of a sudden has less than that. So you have to pay attention to that, but it doesn't matter. At the end of a year, if you list those calories there, does it change behavior? Seems like it would. If you're smart and you see something that has a lot of calories, you don't want to eat many calories overall. Then the second way they did it is basically say at the top of the menu, we make a recommendation for your health that you look at these 4 or 5 sandwiches, that they're healthier for you. It makes kind of sense. That's like the doctor. You go to the doctor's office, they say lose weight, brush your teeth, all that. And so you'd say, well, that's got to have an impact. People are giving you the information you might not otherwise have, who you respect, who they wouldn't put it up there if it weren't factual. And the third thing, sort of the throwaway thing, was put low-calorie sandwiches listed on the first page of the menu, where the customer actually had to turn the page to go to the other sandwiches there. So that didn't make any sense at all to me, because you're obviously going to turn and find what sandwich looks the best or what the calories are. The calories listed absolutely at the end of a year had no impact whatsoever. The people, at the end of the day, maybe the first couple of times they'd say, well, I'll buy that, but at the end of the day, they gravitate to whatever they gravitate to. And what? The recommendation to go to a low-calorie sandwich, nobody paid any attention to it. They said, well, that's nice, but you know, what is that? What do they know? And indeed, the one that worked was the one that required you to turn that page. And I find it interesting because it demonstrates to me that you can't just sort of assume something's going to work, that you do have to build a disciplined construct around it. You actually have to test it. And we, whether we're in management or business, or we who are in medicine, or we who are the economist, or we who are the United States Senator, have to think outside the box. And we have to go to people we may not have paid much attention to in the past, the psychologist, the sociologist, coupled with the epidemiologists and the statisticians coming in. And it's something that we don't typically do. We stay in our own little culture. And that's why one of the reasons that we're going to be teaching this course, or I'm going to be teaching this course this fall. We're going to take hopefully 12 Owen students and 12 medical students and put them in and pair them up and address these big issues. And the whole purpose of that is get us outside of the culture that we think we know so well. So that'll be a fun course as we go through. Disease management, we mentioned, I'm not going to talk a lot about disease management, but I know it's going to come up over the next 2 days. And let me just say, in the very top sentence says that evidence is inconclusive on cost savings from disease management. It doesn't mean that it is not there. It means that if you look at the peer-reviewed published data out there today, the way these studies have been constructed, and again, we're very early in disease management, and this is the data to date, again, putting all the studies together. On the vertical axis here is heart failure, myofibrosis, coronary artery disease, diabetes, depression. These are good. You could put COPD, you could put asthma in there, so there are others, but these are sort of the 4 that I chose. The outcome measurements that we have from these various studies, the black is that there's no effect whatsoever, and the green is it's an improved effect, positive effect, and the red is it's been a negative effect. So guideline adherence, you know, if you have a good disease management program, that you can get good guideline adherence. So that's a good thing, but it's not the ultimate thing. You want health out there. Behavior change, it has either been not really measured in these fields overall, statistically with a good study, or it's had no effect. Pretty interesting, because the whole idea is, and think of it, why do you brush your teeth every morning? I used to ask questions, did you brush your teeth this morning? But then I stopped asking that. But why? We started because you had a parent who basically, you brush your teeth every morning. And you didn't really know why, but you had to go in there and you do it. And that habit with an authority figure telling you and demanding, and probably use a little carrot and a little stick, means you brush your teeth. Well, how are we going to get people, if they have congestive heart failure, to measure their weight every single day, to pick up that increase so you can titrate a little bit of diuretic in there to prevent you in the hospital? How do you do that? We don't know. Nobody does it very successfully today. And what this shows you pretty starkly and embarrassingly, disease control, yes, you get your disease under a little bit better control. Clinical outcome is sort of a wash. Use of services, you can see what it is. Use of services actually went up a lot in depression. It makes sense because most depression is kind of put over in the side. And that's why we passed this mental health parity bill now about 6 months ago to bring it out. But if you bring it out, it means a lot more doctor visits, so a lot more services. But the big thing is on financial outcomes. Overall, you can see that there is no improvement whatsoever to date coming in. Again, not to be discouraging, because this is where I would focus my attention, but right now we've got a lot to do. Prediction, economic uncertainty means that we're not going to see comprehensive health care reform this time around, in spite of what you heard, what I put forward with each of those candidates. Why? Because they just cost too much. The McCain program costs too much the way it's configured. He takes that $300 billion out of the employer-sponsored tax program, but that's really not enough to be distributed across the country to give meaningful reforms, so you have to put more money in it. The Obama proposal, basically, if you were to say everything that he has said we're going to have passed this year, which he doesn't say do that, but it gives you an idea of what it would be like 10 years from now. In today's dollars, would be $452 billion added on. McCain proposal, again, I could put the same thing up there, huge cost. Estimates are that they would both address the uninsured. The Obama would have more displacement out of the private insurance market to the government plan. And the big thing there is just that we're not going to see major comprehensive reform coming in, especially because of this economic uncertainty in the environment. We will see pretty good incremental reform. Cost drives the uninsured. It's number 5, and I put that in there because the candidates are not honest on this. Obama has actually done a pretty good job in at least talking about it in the primary season. And it is pretty clear. In data, you can take any study. This one's out of JAMA from earlier this year. Every 10% increase in the average family health insurance premium, the rate of the uninsured younger than 65 increases by 0.55%. And then they actually conclude any reform to cover the uninsured must address rising costs or it is doomed to failure. Many of you have studied the TennCare program. The TennCare program started in 1993, 1994. Went from uninsured of about 17% in Tennessee down to about 7%. So you promised people coverage, but nothing was done to bend the cost curve down. Some shifting of the cost curve initially, but nothing to bend the curve down. So 6 years later, 7 years later, it was inevitable that you'd break through that. When you have to balance your budget in a state, as you spend more and more on health care, you spend less and less on education K through 12, as well as higher education. And you and I just went through the relationship between health and education. So it is doomed to failure. Massachusetts is doomed to failure. I mean, it'll be good. It'll be even good for another 5 years. You'll improve immunizations, improve access, but ultimately has to be unwound unless we figure out this cost. Again, it comes back. Is consumer-driven medicine and health an approach to that? This is the chart from that study. You can't really see it, but over here is the percent uninsured going up. This is sort of unaffordability, and the way they did it is took the average premium of a state over with the denominator of the median income for that state, and basically it really just shows that the higher the unaffordability, the higher the cost, the higher the spending, the higher the ranks of the uninsured go. So obviously that's going to be intolerable, and you have to address both the uninsured at the same time you're addressing the spending and the cost side of the equation. Where are we going to see the big changes, or where do I predict? It'll be administrative complexity. Right now we have about, I'll show you a chart, about 8 or 9%. For private independent plans, it's up to 30% administrative cost. Right now you have 2,000 healthcare plans out there. We mentioned paperwork. Individual doctors' offices having to deal with hundreds of different plans with different requirements and different paperwork. It's really unacceptable. Medicare has administrative complexity of probably 2.3% of the overall. Overall, our healthcare in the private market is around 8.5%. Every other nation is around 4%. That really shifts the cost curve. It really doesn't bend the cost curve as much, but it shifts the cost curve and has these indirect impact on efficiency in the healthcare system. And also just improves goodwill of doctors and hospitals and all who don't have to put up with all of that. Number two, the economic distortions. I'll come back to that, with the goal being value. Over the numerator, you put in outcomes of some sort over, it could be a disease process, it could be a diagnosis, with the inputs coming in, those economic distortions. And then we talked about the underlying health status of individuals, which at least my voice will be out there saying we got to link education, we do have to link environment, and we have to link what we can do with genetics. And this is just the administrative cost. We're up right now at about 8%. You can see France is actually very high, but you can see everybody else is down around 4% on average in the developed world. There's a lot we can do here. Computers will help, but we've been promising computers will be the solution to this. It is going to take policy change. It's going to take regulatory change in order to do that. Obviously the basics we don't need to go over, but a big problem is you got your consumer here really interacts very little with the provider, whether it's a nurse or whether it's a hospital or whether it's the doctor today. And in fact, there's a huge distortion in here created by the payer and the way the payers are set up, both in terms of the government and the employees. So as we move towards consumerism, we have piled more of the burden on the consumer in terms of deductible and co-payment. And that does have a huge impact, although when you go through a huge downturn like right now, when people just don't have the money to spend, do they stop going to the doctor? We don't know yet, so we'll have to wait and see. This is an interesting slide. Again, you can refer back to over the next 2 days. Out-of-pocket spending as a total of personal health care spending. So yes, at the same time, we're putting sort of deductibles are higher on the individual and co-payments higher, but the way we're configuring them really doesn't put any more skin in the game. So as a percent of all health care spending over the last 40 years, it's gone down and down and down and down. You're shielded more and more by third-party payers. And that gets pretty confusing because this is what all of you get in terms of your bills. And it's a little bit blurry here, but this is a LabCorp bill. And these are services with CBCs and various tests coming in. And these are the charges, and you see the charges were $625, and you're the consumer. So when you talk about consumerism, this is what you get today. And I promise you, if I were to poll you and you were to honest, you don't look at any of this stuff. The only thing you look at is down here, and it's either $5 at Walgreens or it's $20 here. And as long as that $20 is okay, you look at it, it's in the wastebasket. So that's not consumerism today. And the design is not there today. For example, what is this adjustment? The test costs $625. You have an adjustment in here, whatever it is, I can't read it, $500 or whatever. Total insurance paid $29, insurance company paid $9. So none of this means anything. And that's the state of the art today. This was taken from whatever it was 3 months ago or 4 months ago. So the consumer is not involved today. Evidence-based medicine, you'll talk a little bit over the next 2 days about the variation in clinical practice. All of you have seen this data from Winberg out of Dartmouth. It's good data. Won't talk about it today. But why in the world there's a fourfold increase or fourfold difference in the charge and allegedly the cost of cardiac surgery, the same operation, the same quality of hospital in America today. It has a lot to do with the way we price, and policy can affect that map. The map, it basically shows variation in Medicare spending. It's a great atlas. Look at it. It has to be addressed. About 30% of the care given today is ineffective, redundant, or inappropriate. Again, that's why value we have to focus on with full transparency and accountability. That's probably good. Some people say it's as high as 50%, and it comes back to how good is evidence-based medicine. Again, we don't have time to talk about all the evidence-based medicine, but just so you'll have a feeling of the reality of the world that we live in today. In JAMA, an article was published in 1982, and that article basically said that after a myocardial infarction, you should have a beta blocker, which is just a pill. It's a drug. Peer-reviewed journal, the best out there, the most widely read medical journal in the world. And why could they say that? Because it was a known reduction in chances of death by 40% after a heart attack. In 1997, 15 years after that, only 2/3 of the people in something that had been published, peer-reviewed, in the literature, physicians knew, only 2/3 were being discharged on a beta blocker. In 2007, essentially 100%. But that is 25 years after the peer-reviewed, published study that made it clear that you could save lives. And to me, that's really inexcusable. I put in here how many people died over these 25 years. It took 25 years after this publication in JAMA. Well, with evidence-based medicine now, we know that through rigorous research, we can get consensus guidelines and we can get development of performance measures for plans, doctors, and hospitals. But as I said in my opening, people really don't like cookbook medicine. And how good is that evidence-based medicine that's out there? One last slide that I hope you'll talk about a little bit as you go through is if you look through Medicare, and you look at Medicare dollars, just from Medicare data, many of you have actually seen it, the more a state, each of these are individual states, the more a state spends, the worse the quality is. So the whole idea of using dollars as a surrogate measure, even a symbolic measure of quality, you have to throw out the window. And that's why we have to go back to that evidence-based medicine. Pay for performance, I'm not going to talk about, but it's part of where we're going. And I was a part of the policy group that proposed it because it's a little bit like teaching. You don't want to reward the worst teachers, saying you can stay there forever if you're a bad teacher and you're hurting your children. Same thing with physicians, same thing with hospitals. Let's go ahead and reward the people who do well, and by default, the people who don't do well in sort of a market-based approach are either going to have to get out of the system or they're going to have to go learn how to do better. It's not new. This is from 1750 BC. If a physician makes a large incision with an operating knife and cures it, or if he opens a tumor over the eye with an operating knife and saves the eye, he shall receive 10 shekels in money. If a physician makes a large incision in the operating knife and kills him, or opens a tumor with the operating knife and cuts out the eye, his hand shall be cut off. So it's not new. It's been around. There are ways to do that. An example is on IT. You'll be talking about health IT. The bottleneck is with physicians today because physicians see health IT, information technology, is good for the system, good for the patient, good for the insurance companies, good for society, but it kills me as a physician. Instead of seeing 15 patients in a day, I can only see 10 because I got to go and type all this stuff in the computer, and the computer breaks down, the data sits there, it's not very useful. The bottleneck is the physician. Now we passed a law the other day that you pay a physician 3% more if they use e-prescribing or if they use the computer. And you start bribing them a little bit, then over the long haul, they'll see and they get things set up, and you'll get over that activation barrier. So the bottleneck is actually there. Vision, let me just show you, well, this is what we need to do. We have to restructure our health system based on value itself, and how we determine what that value is comes back to the evidence-based medicine, what the outcomes are. We need a dynamic system because Tennessee didn't get it right, Massachusetts didn't get it right, California didn't get it right, the federal government has not gotten it right. So we have to recognize that we're going to learn as we go. And we do need to experiment. We do need to have demonstration projects. We do need states out there with their innovative plans. And have the government be the enabler, not the driver. I say that as leading this legislative body of government, that if you turn it over to government, they'll be enabled because you can't micromanage these billions of healthcare decisions that are made every day. So the world that I see is one that is provider-friendly, individual-centered, that is consumer-driven, is driven by 21st century information that we simply did not have when I was doing heart transplants every day over at Vanderbilt 15 years ago. Now we have that information today. Secondly, I do think it needs to involve choice, where we do have hundreds and thousands and millions and indeed billions of healthcare decisions with an accountability built in, having an impact on quality and on access and on some element of my last point, control. Right now, there are 45 million people out there who don't have health insurance today. It'll probably go to 52, 53 million within 2 to 3 years. But remember, of the 45 million, 11 million of them have a health care plan that's available to them today, that's paid for in Medicaid and S-CHIP principally. So the 45 million, 11 million have a plan. Another 11 million are not United States, of that 45 are not United States citizens. So we got to figure out what we're going to do. What is our responsibility with taxpayer dollar? Again, it goes back to my ethics. And then about 11 million, as you know, make more than $50,000 themselves. So there's a hardcore group of 11 million, and we have to have some element of control, whether it's through vouchers, to be able to take care of those individuals. So I think with that, I will, being 9:30, I will stop. I'm very excited about the future of healthcare today. Today we've talked about a lot of the concepts that I hope will set a platform through which you can both insert information over the next 2 days, but also build on as we go forward. It's an honor to be with all of you. Look forward to engaging with you as we go forward to solve these really big problems that are out there. Thank you very much.